Hi, everyone. Happy Monday. Thanks to those of you who joined early Pacific time. And we are kicking off our November 16th annual eConsult meeting. We're so glad to see you all today, a lot of new faces and some familiar ones too. Our session today is featuring Dr. David Shulkin, along with the SAFETYNET Connect team, who will be doing our first fireside chat. So if you're not speaking today, if you wouldn't mind turning off your audio or turning off your video, and we'll let you engage in our discussion in just a moment as we get started. So I'm going to hand it off to Chris Cruttenden, the president of SAFETYNET Connect. And Chris, if you wouldn't mind introducing our speaker today, Dr. David Shulkin.
All right. Thank you, everyone, for joining us. Thank you, Dr. Shulkin, for joining us. I'm going to actually play a nice little video intro of Dr. Shulkin. Just give me a second here. And share that. And can everybody, here we go. I'm going to make that large. Can everybody see that?
Yes.
All right.
I appointed today the head secretary of the Veterans Administration, David Shulkin.
You are the only holdover from the Obama administration. Were you surprised when President Trump picked you?
I guess I'd have to say yes.
It is the government's second largest department with more than 300,000 employees and an annual budget of $200 billion.
I've come here for one reason, and that's to improve the lives of veterans, and that's what I'm focused solely on doing.
He actually passed 100 to nothing. When I heard that vote, I said, where did that come from? 100 to nothing, right? Passed 100 to nothing.
Does the president ever refer to you by your title, or is it always Mr. 100 to nothing? Because he refers to the fact that you were unanimously approved by the United States Senate.
One of the things most Americans don't understand is that when you send men and women off to war, it sometimes takes decades before you see the impact of that demand.
There are a lot of important jobs in government, Mr. Secretary, but yours may be most important.
The VA secretary, who is, by the way, just doing some job, and he's doing it with this and with the heart.
But he is making big changes.
I have no doubt it will be properly implemented. Right, David? Better be David. We'll never have to use those words. We'll never have to use those words on our David. We will never use those words on you, that's for sure.
And so when it came to the issue of privatization of the VA, I simply stood up and said, I am not willing to go that far.
He was fired by state.
Yeah, I didn't have a lot of warning.
Dr. Shulkin criticized the administration this morning in the New York Times, alleging he was fired because he disagreed with plans to privatize much of the VA's functions.
The big issue that I clashed with the administration on was how much we wanted to privatize the VA. We do not give a blind political loyalty to any administration. That you have to stand up for what you believe in, and you have to have principles for what you believe in.
David Shulkin with us right now, the former VA secretary, by my money, the best VA secretary we have ever had.
You're right. It should not be this hard to serve your country, our broken government, and the plight of veterans.
Suffice it to say, I've covered this very, very closely for decades. No one did more for veterans, and I'm saying no one, that this gentleman.
I appoint.
All right. Great video intro. Thank you so much for joining us, David. Let me close that out for myself. And so before you actually became the Secretary of the VA, you were running hospitals in the private sector. So what caused you to leave your job and actually go into government? Uh-oh. Did we freeze up, Libby?
No, I'm here. There's an announcement going on, so I was just waiting.
Oh, okay.
Can you hear that? Oh, you can't hear it. Okay. For some reason, I have somebody speaking to me from the general audience. So just hold on one second. Okay. Okay. I apologize. I'm sorry. I keep on getting an announcement, but hopefully that will stop. So thanks, Chris. I really appreciate the opportunity to be with all of you this morning, and hope we can have a fun conversation and make it topical as well. Yeah, you're right. I've spent my career running healthcare systems. I was the CEO at the time of a health system in northern New Jersey. And I got a call from somebody that I didn't know who said that he knew I'd be at a conference in Washington and whether I would like to have lunch with him at the Metropolitan Club. Now, the Metropolitan Club, that some of you may know about Washington, is a pretty elite club. And I certainly wasn't a member and didn't ever plan on necessarily getting invited. So I agreed to go to the lunch. And you know that old saying, there's no such thing as a free lunch. We had a pleasant lunch, and at the end of the conversation, as we were leaving, the person I had lunch with said, boy, you've had an interesting career. Do you have any regrets? And I said, you know, maybe only one. I'm reading in the newspaper and watching on TV about this horrible wait time crisis for our veterans. And if there's anybody in the country that I think deserves the best health care that we can give, it's our veterans. And I just feel really bad. I can't do anything about it. And he shook his head and said, yeah, I understand that. And after I was done the lunch, I actually got back on the train to head up to New Jersey, where I was returning to work. And I was about an hour into the train, Chris, and my cell phone rang, and I picked it up, and they said, is this Dr. Shulkin? Is this Dr. Shulkin? I'm hearing that announcement again. I'm sorry. I'm going to try to talk over it. So they said, is this Dr. Shulkin? I said, yes, it is. And I'm sorry. I don't know if everyone else can hear this announcement.
No.
And
I'm so sorry, Dr. Shulkin. We're not hearing anything. So
okay.
Apologies.
Okay, good. So anyway, they said, this is the White House, and we'd like to talk to you about help with the VA. And it was an hour after this phone call. And at first I thought somebody was playing a joke on me, but they weren't. So I actually returned to Washington later that day and went and met with the White House. And ultimately, that led towards me coming to try to fix the wait time crisis at the VA, which, if people remember, this was in 2014. There were allegations of thousands of veterans actually dying or being harmed because they couldn't get appointments at the VA.
Thank you for that. So, yeah, I mean, we've all heard the horror stories about it, and but I don't know if everybody actually understands the VA unto itself, what this organization is and does. Could you just give a little background on that?
Yeah, the VA, which is a government organization, is actually the second largest government agency. So the first largest, of course, is the Department of Defense. There will be about 2 million people in the Department of Defense. That's the military. The second largest agency is the VA. There are around 430,000 employees in the VA. Just to give people a comparison, the State Department has about 20,000 employees. So the VA is a very large organization. It has an annual budget of about $220 billion a year. And it has 1,600 facilities throughout every part of the country, even in different parts of the world, really wherever veterans live.
Wow. So there are so many issues facing veterans. What did you determine as your priority when you came in? Obviously probably wait times, but was there anything else that was on the top of your mind?
Yeah, certainly. When I entered government, so I was asked to consider being President Obama's person who led the VA healthcare system in 2014. Chris, it took about 11 months to get through what is vetting, which is going through all of your background and then getting confirmed by the U.S. Senate. But when I arrived at the VA, it was about 15 months after the wait time crisis had actually begun. And unfortunately, when I got there really were no plans in place to solve that issue. So my immediate issue was to fix the wait time crisis. And I'm pleased to say by December of 2016, right as President Obama was ending his term, I was able to tell the president that we indeed had fixed the wait time issue. And by that, the way that I went about fixing that was to ensure that every VA across the country had same-day appointments in place, because that was the only way that I knew how to ensure that a veteran wouldn't be waiting for care, to be able to deliver care when they needed it on the day of service. And so that was the initial priority. When I was able to assure that we had addressed that issue, adequate access, the single highest priority that I established as VA secretary was the issue of veteran suicide. And 20 veterans a day take their life through suicide. And that's a staggering number. It's about twice as high as the general population. And despite lots of efforts to try to address it, it has continued to be a very, very difficult problem to have an impact on. So that's why that was established as the single highest priority that I had.
Do you find when you have to come in and solve these massive problems, a top-down strategy works, or is it more of a regional strategy depending on the location and the culture of those locations?
Yeah, it's a great question. I had not worked in government before coming to the Department of Veteran Affairs. So it was a brand new culture for me. And again, I apologize, I'm hearing those announcements. So I had to really try to understand the culture of the environment that I was walking into. And the VA has a culture very similar to the military. And that is a very top-down culture. So people literally wait until they get instructions. They're actually called directives in the Department of Veteran Affairs. And once somebody gets a directive or a top-down instruction, they are very, very good at carrying out those issues. So I had to use that culture to be able to set such a big organization on a course and to set priorities. But on the other hand, all my experience in the private sector really told me that that was not the way that you were going to get the type of lasting change and to get the involvement of the frontline employees. So I really created a dual strategy. First, to make clear what the priorities of the organization were. Secondly, to give the direction that we were going to accomplish that. But then I set about trying to change the culture to begin to empower those who were taking care of patients closest to the patients to have the ability to start having an impact. And, I did that a couple ways. First of all, one of the things I've always done personally, I'm sure many of our leaders on the phone do this as well. I wanted to make sure that I understood the environment of the organization that I was leading. And so I would put on a white coat, not as secretary, but as a doctor, and I would go take care of veterans in the VA medical centers. I also would take care of veterans from my office in Washington using telehealth in places that frankly didn't have physicians, where there was a shortage of physicians. I would raise my hand and say, well, I'll take care of veterans in that rural clinic. And so after I began to understand some of those issues, what I wanted to do was to empower the people working closest to the patients. And I started to create a forum to share best practices. So VA developed a platform similar to Facebook, but it was for government VA employees. We called it VA Pulse, where you could share best practices with other staff and begin to start trying to understand what was working and what wasn't working in the context of the VA. And then we started to do Shark Tank exercises, where I'm sure many of you have seen the hit show on ABC, Shark Tank, where people come and present their ideas to billionaires who put their money behind these types of new ideas. But in the case of the VA, of course, we couldn't do that. So our sharks were the CEOs of our VA medical centers, and they would bid, not with billions of dollars, but they would bid by committing that they would implement that best practice, those ideas in their own VA. So these Shark Tanks began to start getting VA medical centers around the country adopting these really good best practices. And that began to empower the frontline workers to bring more ideas forward and begin to spread them throughout the VA. And that was part of what I saw as a beginning of a big cultural change in the organization that translated into improved morale, improved outcomes, improved trust of our veterans.
I love that. That's a great strategy. You did mention telehealth in that, and it's funny. Some of that strategy reminds me of eConsult, maybe a bit of a stretch, but the asynchronous communication, talking about best practices and triage and how to best help the patient. At what point did you realize that a telehealth strategy could effectively address some of the access issues and wait time issues at the VA, and maybe even pop health for that matter?
Sure. Yeah. So in addressing the wait time issue, I understood that the wait time problem, and this is how telehealth connects to it, the wait time problem was a very complex problem that had developed over decades. It was actually a perfect storm of veterans that were coming back from our new conflicts like Iraq and Afghanistan with serious injuries that frankly we hadn't seen before, largely because of the IEDs, the improvised explosive devices that were tearing off limbs and body parts off of our military. And because of modern trauma techniques, in the past, these people probably would have died, but now they were surviving. So they were coming back with very complex injuries and traumatic brain injuries as well. But also many coming back with the invisible wounds, such as post-traumatic stress. So that was putting a big demand on our system. But even probably more importantly was our Vietnam veterans who were turning about age 70 in age, and because of the aging demographics required much more in terms of medical care. So the confluence of those overwhelmed the system. So to fix the system, we did a large number of things, including giving our nurses and pharmacists independent practice authority, expanding the number of people that we hired, publishing our wait times publicly, but certainly using telehealth, because the VA is an unusual health system in that it has to provide care anywhere a veteran resides, whether we have a physical facility or any personnel in that area. And 40% of veterans live in rural areas. So that's a big challenge for the VA to deliver care. So telehealth was a natural technology to be able to use. And the problem that I ran into in using telehealth was the same that the private sector was running into. Even though I, as the VA secretary, could use what's called federal supremacy, I was allowed to go above state law. So theoretically, I was able to say that any doctor or nurse or pharmacist in New York City could provide care to veterans in rural Kentucky or in Alaska. But when I tried to do that, I was blocked by federal bureaucracy because the VA's lawyers were the Department of Justice, and the Department of Justice refused to essentially defend us in a case where a state said that we could not do that. They would not support my federal supremacy laws. So what I did was I took advantage of the relationship that I had with the White House, and I asked the president whether I could come over to the Oval Office and actually show him how I took care of patients, veterans, using telehealth. And so I brought my telehealth equipment to the Oval Office, and I started to take care of patients, showing the president how I did that in a rural clinic in Oregon. And after I finished an examination, the president said, "Boy, that was great." And I said, "Yeah, Mr. President, that was great. But unfortunately, we can't do a lot of that because the Department of Justice is not willing to cooperate with us and to defend our cases." And the president said, "Well, let me see if I can help you with that." And a week later, the Department of Justice all of a sudden decided that they were willing to support us. And so now today, anybody in the VA can practice telehealth anywhere in the country. We were able to get rid of all the barriers and regulations that up until the COVID crisis, the private sector also faced. We're now seeing in the private sector a ability to free up those regulatory barriers as well, which is really, really good news for, frankly, all Americans, because telehealth is a technology that clearly can help many, many people in a crisis like the pandemic, but also well beyond that. So telehealth became an important way that we addressed providing access for our veterans.
Yeah, and kind of sticking with the mention of the pandemic, I mean, it seems like telehealth is the obvious answer, especially eConsult, my personal opinion. What do you see next as far as, looks like we're going back into lockdown, and how telehealth can address some of these pandemic issues that we're facing right now?
Well, I would just make sort of three general comments about telehealth. Of course, Chris, we could talk about telehealth and what's going to happen with it this whole time, but let me just focus on three things. First of all, I do believe that we are going to be moving to a telehealth first strategy. That means that ultimately access to care, I believe, in large part will start with a telehealth visit. And that allows people to get care quickly, conveniently, to match resources of where demand and supply are. And then from there, if telehealth is not the appropriate modality, or if additional care needs to be delivered, then you move to the next phase. So I call that a telehealth first strategy. And I just believe that makes sense. Secondly, I do believe that what people today define as telehealth is just the beginning of what we're going to see. Telehealth, most people define as a video visit. That's really a very primitive form of what this technology can do. We need to begin to start being able to match people to the right type of expertise. And that's going to require a relatively limited, but certainly practical form of artificial intelligence, where you can match people who are seeking help to the type of professional that has that expertise and, frankly, addresses the patient's preferences in terms of finding health professionals that relate to them in a cultural competency type of way, and maybe the right type of gender, the right type of digital experience, who can, is willing to take a look at their wearables and other types of devices. Not all healthcare professionals are willing to do that today. So I think we're going to move to a much smarter, sophisticated type of telehealth in the future. And I think we're beginning to see that as it expands from sort of episodic care to more of a continuum of care and chronic care management using telehealth. And then third, I think that what you're doing in SAFETYNET is really an important part of what health systems are going to need to do in the future. And that is to be able to develop their capabilities using asynchronous technology to be able to capitalize on the expertise in their network. So what you can do with eConsults is to be able to utilize a primary care physician to get assistance from a specialty physician. And that begins to leverage the expertise and coordinate care within a system. So I think the combination of using asynchronous technology like in SAFETYNET Connect and the ability to add smarter technology and more across the continuum of care, like in chronic care conditions, is really where telehealth is going to be going.
All right, thank you. So working in the private sector as well as the government sector, is there something that you've learned from both experiences that can be applied to overall healthcare in general?
Yeah. As I mentioned, I was in the private sector when President Obama asked me to come in to address the wait time crisis. And I thought, quite frankly, that I would come in and I would fix government. I would show all of the people who worked in government how the private sector does this and use the best practices that we had found in the private sector. But in fact, my experience turned out to be exactly the opposite. I learned so much more about what works in the VA system for improving healthcare outcomes that, quite frankly, there is many, many more of these best practices that I believe the private sector needs to learn from government. So let me just talk very briefly about that. The big difference between the VA and what most people have to do in the private sector is the way that we're paid. In the VA, I would go to Congress each year and I would say, in order to take care of the 20 million American veterans, the 9.5 million that get health care in the system, and the rest of the veterans who need other services, I need a certain amount of money to do that. And Congress gives me that money in a budget, and then as VA secretary, I determine how that money should be spent. And that's really very freeing to be able to focus on the needs of a population of patients, as opposed to what happens in the private sector is you have to operate in the context of what the rules and regulations are of a reimbursement environment. In other words, you have to focus on what you get paid for in order to keep your business sustainable. And so in the VA, if a veteran is homeless, like 45,000 veterans are across this country, it's really hard to provide good health care to somebody who doesn't have a home and doesn't have security and safety. So we find those veterans safe places to live, and we find them homes, both short-term and then permanent housing. If somebody doesn't have the economic means in which to be able to provide care for themselves and to be able to, keep themselves healthy and well-being, we provide economic assistance. If they can't provide medications, we provide that. Transportation to facilities, peer support systems, caregivers that aren't reimbursed in the private sector. We know what a big deal and difference they can make. Every VA hospital has suicide prevention coordinators. You don't find them in the private sector very frequently because they're not a reimbursed position. So these social determinants of health that we all hear about are really part of the way that healthcare is delivered in the VA system. And that is really a very, very powerful way of impacting the health and well-being of people. So that's the biggest lesson that I think that I've learned from government, that looking at not just the physical aspects of care, but the psychological, the spiritual, the economic aspects of care, I think makes a huge difference.
So many leaders have aspirational goals, and it seems like you're seeking big changes and you've made big changes. Can you share one of those goals that you're working on currently? Yeah,
well, I do think sometimes as leaders, people focus on incremental change. And I believe sometimes that's a harder strategy than focusing on a big goal and making clear to the organization that you lead why it's important to accomplish something. So I'll I'll use an example of one of the strengths that the VA has is it has everybody in a single electronic health record for over 30 years now, since the VA was one of the first to establish an electronic health record. And so it was very easy for me to find data and to find good comprehensive data. So I asked the question, how many veterans had hepatitis C? And the reason I asked that question, it was because when I was secretary, we just saw the introduction of new drugs that essentially cured hepatitis C, at least at the 95% level. So I asked the question, how many veterans had hepatitis C? And the answer came back 167,500 of our patients had hepatitis C. And so I made the decision that I wanted to eliminate hepatitis C among all of the veterans in this country. And when I went before Congress at a hearing, I purposely, in response to a question from a senator, made the statement that I was going to cure hepatitis C or eliminate hepatitis C. And I knew, quite frankly, that the senators would approve of my doing that because they cared about making a difference in the VA system. And as soon as I got some of the affirmations from the senators that that was a good thing to do, I said, now all that I need is $1.5 billion to pay for it, because I didn't have the budget to buy enough drug to treat 167,500 veterans. But they gave me that $1.5 billion. And then we went out and we contacted every veteran who had hepatitis C and called them into their medical centers and went through a process of explaining how we could treat them. And today, there would be less than 10,000 veterans in the VA system that have hepatitis C. So that's really an approach towards population health, and something that I think many health systems across the country who are beginning to view themselves as integrated systems or payers working with providers can begin to start thinking about population health in that type of way.
Wow. That's great. So obviously some interesting stuff is going on politically right now. We are watching the current situation with the election and the transition of power, and you have personally gone through that. Can you share some thoughts about that process?
Yeah. So I had never really understood what these transitions meant. And of course, I was there during the transition the last time this happened between the Obama administration and the Trump administration. And I would just tell people that my impression was that this was one of the most vulnerable times for our country. You literally have 4,000 political appointees, the ones who lead every agency in our federal government, get up and leave on January 20th at 12 noon. And there aren't 4,000 people to come in and replace them, because it takes a while for the political appointees to be appointed. 1,250 of those have to get confirmation by the US Senate, which can often take months. My confirmation when I first went to government took 11 months. So you have these agencies really without people that run them. And then when political appointees do enter, they have to learn their jobs. Many of them have come from the private sector like me, who don't know much about how government agencies work initially. So having a proper transition where there is comprehensive planning, where there are detailed documents that show how government should have a continuity of operation, and what do you do when there are crises and emergencies, it is really critical. Now, the last transition that I went through 4 years ago, we didn't have a health pandemic going on. I can't imagine a more critical time that we need close coordination and planning so government is able to react and to continue its operations than now in the midst of a worsening health pandemic. So, I feel strongly that it is essential that we do not delay any further that we begin a transition planning process and cooperation between the outgoing and the ingoing administrations. That's not a political statement. I think, the president can continue to pursue his legal options, if he wants to do that, but there really is no reason not to begin the transition planning that is legally required and is in the best interest of the country.
Yeah. So having worked in the Obama administration, and you did have the opportunity to work with Vice President Joe Biden at the time, can you share a little bit about his style and how you think he'd be as president, and how selfishly that would help us in the healthcare world?
Yeah, absolutely. I think that I worked probably closest with Vice President Biden as he led the Moonshot Initiative. And that was really, the Moonshot Initiative, as many people may remember, was intended to try to accelerate a cure for cancer and frankly, to improve the way that we deliver cancer care across the country. And I represented the Department of Veteran Affairs in that, but every federal agency that touched cancer, from the Department of Energy, the National Cancer Institute, the NIH, the Department of Defense, the FDA, the CDC, everybody was in a room on a regular basis with the vice president driving that process for us to work together. And frankly, I thought it was an incredible process and was extremely disappointed when the Trump administration decided not to continue that. I have no doubt that the president-elect will bring back the moonshot because of his commitment to scientific research and to advancing the care of cancer. Of course, as you know, his son, Bo, just when he was vice president, passed away from brain cancer. But the vice president is very methodical, is a good listener, wants to hear from experts, is fascinated by topics like this, and likes to roll up his sleeves and get involved in it. I expect in a Biden administration, particularly when we have most likely, although we're going to have to wait till January 5th to see, but potentially a Senate that is still Republican controlled, that we're not going to be seeing large legislative changes. We're not going to be seeing the types of, reforms that many progressives were hoping for, but we're going to see largely the ability to create change through what I would call regulation. The Department of Health and Human Services largely can change the way that healthcare is delivered by rulemaking and regulatory change, and doesn't have to do a lot of legislative change unless it was going to be a major overhaul of the way that our Medicare program works. So in these regulatory changes, I expect there's going to be increased support for bringing back many of the reforms of the ACA that we saw rolled back during the Trump administration. That means greater subsidies for the exchange products. That means probably rolling back some of the state requirements for work requirements to be enrolled in Medicaid. It means greater incentives to states for Medicaid expansion. It means rolling back some of the exceptions in the religious and moral waivers that were given to providers and employers who didn't want to participate in some of the ACA programs. And I think that we'll see some continuation of many of the programs that, frankly, the Trump administration had worked towards, which is an encouragement of value-based value-based payment programs, an encouragement about being able to negotiate for drug pricing, the transparency rules, the surprise billing legislation, the interoperability of healthcare data. I think those are all things that will go forward. So I think that we will probably see a very thoughtful, comprehensive process go into place. But in the end, at least until the midterm elections, if there's a change in the control of the Senate, or if Georgia does control the change of the Senate, I would expect generally supporting of the ACA, but not major legislative changes.
Great. And if you, when you're helping with the transition, anybody in the new Biden administration wants an eConsult demo, we'd be happy to provide that.
Well, I think having an eConsult national program would actually be, as I said, one of the things I do believe that both the Trump administration had made great progress in expanding telehealth capabilities by giving some reimbursement parity, but mostly through regulatory relief. I expect the Biden administration will continue to support and accelerate additional access with telehealth. But as I said, one of the components of a telehealth program, I believe, should be an asynchronous component, because expanding the internal capacity of network expertise and also network efficiency by leveraging, primary care doctors and specialty care doctors together to provide patients the right type of care. I do think that should be part of a national strategy.
Right. So you've had pretty amazing experiences and actually a really positive impact on our healthcare system, especially through the VA. What is maybe one of the most fun or unusual things that have happened to you throughout your career?
Well, I do feel extraordinarily privileged to have so many of the experiences that I've had, and clearly to me, when I think back upon what was most impactful, it was spending time with those who have served and sacrificed in their families. There's no question about that. But I think, some of the experiences that I think are pretty unique. I think of one. I will often, just to relax in the evening, watch a little bit of TV before I go to sleep. And one of the shows that I had just begun to start watching was a show, I think again, it was on ABC, called Designated Survivor. And I don't know how many of you have seen it, but it's actually based on a true story or a true scenario, not a true story, where if government is disrupted, there is a succession plan to take over in government. I was actually in presidential succession as secretary, because it goes into the cabinet should members of the administration no longer be able to serve. And on the first State of the Union address, where all members of government and the Supreme Court and the military all gather in the state capitol, they leave one person out in the secret location. Should that building blow up and everybody no longer be able to serve, the designated survivor becomes the president. Now, one day, about a week before the State of the Union, I was in my office in Washington and the phone rang, but I picked up the phone on my desk and there was nobody there. The phone kept on ringing, and I soon realized there was another phone way off in the corner, which I'd never seen. And so I walked over to it. It was against the wall. I picked up the phone and they said, "This is the White House. This is secure communication. And we want to ask you to be the designated survivor." The only problem is you can't tell anybody. You're not allowed to tell your office staff. You're not allowed to tell your own security force. You're not allowed to tell your family. This has to be a secret, because the way that it works is that nobody knows who the designated survivor is until you literally don't show up in your seat in the Capitol building. And so everybody has to think that you're going to the State of the Union. So about an hour before the State of the Union started, my secretary out in the front of my office came running in, sort of panicked, and said, "Mr. Secretary, there's about 20 Secret Service agents out here saying that you have to come with them." And she, of course, was very concerned about that. And I said, "Look, that's okay. I know what that's about." And then they brought me to a secret location where where I was able to watch the State of the Union. And fortunately, nothing happened, and I was able to return home that evening. But at least for an evening, you literally are prepared to take over and to continue the role of government should anything happen. And that was certainly a unique experience.
Well, I felt like we were in good hands if anything did. So my final question for today, and then I'll leave some time for the panel or the group to ask some questions. But you left office and you wrote a book called "It Shouldn't Be This Hard to Serve Your Country." Great title. Can you tell us a little bit of why you wrote the book?
Yeah. So I was fired by tweet by President Trump. Now, at the time that I took the job in government, I had no idea that was even a possibility. I never heard of anybody being fired by tweet. But now with 19 cabinet members going through the cabinet in the way that they have, this has become a pretty common thing. We just saw it last week, as Mark Esper was fired by tweet in the Department of Defense. But the experience of being fired by tweet is you don't have a lot of time to know and to prepare for leaving office. So here you have people in charge of departments like myself that had really spent years learning that job. And I had finally found, I think, a formula for fixing the VA. I mean, we were making great progress. And then all of a sudden that stops. And there's no process for sharing the information. There was nobody I could go to after that tweet and say, look, let me tell you what was working, what wasn't working. Here are the people that I was working with to get this accomplished in the Senate and the Congress. Here's where I think you should really make sure that you watch out. It's just a complete loss of knowledge. So one of the reasons I wrote this book was because I felt an obligation to put down how we could continue to improve the care for this country's veterans and what this health system needed to look like. It's a big system and it was going to take years to change. And I didn't want that knowledge just to dissipate. And so in many ways, I wrote it for the country's veterans, because I do believe that when you go off and you serve and you sacrifice, you shouldn't come back to a system that doesn't work for you. And frankly, it shouldn't be this hard to serve your country to be able to get the type of care that you needed. But the second meaning of that same title of the book was about my own personal experience of going into public service. And, I do believe that when your country asks you for help, I was a CEO of a health system, pretty happy at my job. And I got up and I left that to go in to what was a pretty tough job because I felt that I could help. And I think that most people would feel that if they could help and the country needs them, that they would go and do that. So public service is something I strongly believe in. But what I experienced in my personal story of what my family and I went through, particularly in the Trump administration, with much of the chaos that people have watched on their TV screens over the last 4 years, was such a difficult situation that we need to do better in this country. This partisan divide that we have, the personal attacks and sabotaging that I personally experienced and my family did as well, is something that I think keeps many people from choosing to do public service. And so here we are at a time in transition where we need the best and brightest in the country to raise their hands to go and serve in the new administration. And I really want the very best that we have to do that. So in writing this book and talking about what this environment is like, my goal is, and my hope is that we will not put people through this type of experience in the next administration and future administrations. And so it's really intended to be a helpful book to show, what this is like when it can go wrong and why it's important that this go right, because public service is the way our government runs.
Great.
Thank you, Dr. Shulkin. Chris, I was just wondering if you want us to read a couple of the questions that have come in for you?
Please, go ahead.
Great. And I'm sorry to cut you off. There's so much to be able to discuss, and I wish we had more than an hour. Our first question that came in was from Jonathan Howell, asking what Dr. Shulkin's thoughts are on a nationwide patient ID system.
Well, Jonathan, thanks for that question. I think it would be an important step forward. One of the important issues that I worked very, very hard on was establishing the ability to have interoperability of data. I actually made the decision to move away from a homegrown electronic health record that was very much liked in the VA system to a commercial system because I needed the Department of Defense and the Department of Veteran Affairs to be able to share clinical data. And so many of the interoperability rules that we're seeing put in place today actually originated from the Department of Veteran Affairs to be able to do that. It's called Blue Button technology, and it's very important. And a national patient ID is the beginning of a standardization of data sets in conjunction with these interoperability rules and technologies that would allow us to really be able to share data, to be able to help help all patients get the type of care that I think that we need, and to try to decrease many of the fragmented and gaps in care that we're seeing still on a regular basis. So I think that would be a step forward.
Thanks, Dr. Shulkin. And I'm going to fire off a couple of the other questions since we do have a hard stop to get back to our main session. And our next question from Michael Fratkin is a little complex. I'm not sure if we're going to have time for this, but can we contrast primary care with palliative care, chronic care management as a telehealth adjuvant co-management delivery model? I don't know if you can read that, Dr. Shulkin, if you have a quick response to that. It's hard.
No, I mean, I can't read it, but frankly, I think that's a really powerful idea, and it's part of both the ability to use technology to bring in the type of expertise together, but it also fits back with the asynchronous technology that, frankly, SAFETYNET Connect is doing, which is allowing clinicians to share expertise, to work together in a team approach to deliver the patient the best solution. And palliative care and, that type of expertise is really needed in many, many situations. So it's a great question.
Thank you. And we have one last one here from Milan Parek. Should a national medical licensure system be considered a viable solution to overcome state regulatory hurdles when implementing telehealth?
Yeah, I happen to believe that the state solutions or the state credentialing and regulations in many cases turn out to be much more about protecting local business practices. And so I believe that our goal as a country is to provide the best access to care to every citizen, and that is going to require the ability to match where the supply of healthcare professionals and expertise is to where the patients need care. And that would require a national system like this, and a national credentialing and a national licensure. And so if you take out people's own personal economic interests and protectionism, and you look at what the goals of the country and of what citizens should be, it would lead you towards that type of solution. So I think that is something we should look at. And of course, that's exactly what I did in the VA, is use that system to deliver care to people wherever they were.
Dr. Shulkin, thank you so much for your time. Libby had to jump to the next meeting, and really appreciate it. And even looking at some of the comments, a couple people who worked with you said you were the best secretary of the VA, and it was a real pleasure getting your insights today. Thank you so much.
Thank you so much.